Hi everyone, in this video I'll be discussing another beta-lactam. It is called cephalosporins. Now, as we discussed in penicillin, penicillin also obtained from fungus. Similarly, cephalosporins were also obtained from fungus. So it's an antibiotic. So we currently have 5 generations of cephalosporins. What is the mechanism of action of cephalosporin? It's similar to beta-lactams. They bind to penicillin binding protein. They inhibit the enzyme transpeptidase. And by inhibiting that, they inhibit the cross-linking and they inhibit the cell wall synthesis. And these are bactericidal drugs. So totally we have 5 generations of cephalosporins. Since these drugs are obtained from fungus, there is a risk of allergy, that is hypersensitivity type 1 reaction with them also. Let us start our journey. Cephalosporins, and the mechanism of action is they inhibit the enzyme transpeptidase. So by inhibiting that, they inhibit the cell wall synthesis. They inhibit cell wall synthesis. And these drugs are, yes, bactericidal drugs. Bactericidal drugs. So that is the mechanism of action. Now, once we know the mechanism of action, it's important that we understand the spectrum of action of this. Spectrum means what do they cover? Spectrum. So I told you there are totally 5 generations of cephalosporins. Let me write like this: the first generation, the second generation, the third generation, fourth generation, and the fifth generation. So there are totally 5 generations of cephalosporin. You need to just have a rough idea what do they cover. Now when we talk about the first generation, remember first generation, if I am writing big word, the big letter, that means it is covering more. So the first generation is going to cover more of gram positive and less of gram negative organisms. Now moving on to the next generation, the second generation are going to cover gram positive a bit, gram negative a bit, but they are going to cover mainly anaerobes. So their major activity is on anaerobes. So this is their action, second generation. Moving on to third generation also cover gram positive, but their major activity is on gram negative. That's why I have written it bigger. So third generation means gram negative action, and also they can cover anaerobes. So they have activity on anaerobes. So that is the third generation cephalosporins. Coming to the fourth generation, they also cover gram positive, but their major activity is on gram negative. So which gram negative? We use them in resistant cases. So these are reserved drugs. We don't use them left and right. So we use them for resistant cases, that is the fourth generation cephalosporins. Now, fifth generation cephalosporin has anti-MRSA property. So it is the only beta-lactam which works on MRSA. Please mark this point, MCQ. It is the only beta-lactam having MRSA action. It will also cover gram positive as well as gram negative infections. And it is also used to treat the CAP. CAP means community acquired bacterial pneumonia. So this is the idea for you. What is the spectrum? Remember, the first generation is mainly active on gram positive, second generation on anaerobes, third generation again for gram negative, fourth resistant gram negative infections, fifth MRSA, and second and third generation have activity on anaerobic bacteria. So once we know this, let us understand which bacteria are not going to be effectively killed by cephalosporins. Cephalosporins are ineffective. They are not going to work on these bacteria. Very, very important. They are not having any clear activity on them. So we will remember by the mnemonic the male. What is the M for? M for MRSA. You know the reason for MRSA? Altered penicillin binding protein. So no beta lactam works except the fifth generation cephalosporin. So cephalosporins don't work on MRSA except fifth generation. A for the atypical bacteria. So what are the atypical bacteria? They are Mycoplasma, then Chlamydia, then Legionella and Rickettsia. So they don't work on these things. They don't work on atypical bacteria. They don't work on that. So that's why when there is community acquired pneumonia, there is a chance of infection from typical bacteria as well as atypical. So what are the bacteria which cause atypical pneumonia? Legionella, Chlamydia as well as Mycoplasma. So there was a question in your previous exam. Why do we combine beta lactams with macrolides? Now beta lactams, they don't cover atypical bacteria like Mycoplasma, Legionella as well as they don't cover the Chlamydia. So that's why we add macrolides which can cover these things. So that is one question. Second, will cephalosporin kill Mycoplasma? What is the reason for that? The reason is Mycoplasma lacks cell wall. So any drug which acts on cell wall cannot kill Mycoplasma. That is the reason for that. So please mark these 2 points. So it will not work on atypical bacteria. Now L stands for it will not work on Listeria. So Listeria, it will not work. Listeria monocytogenes. So what is the drug of choice for listeriosis? It is ampicillin. Now E stands for enterococci. So they don't work on enterococci. So you know male, and if you know male, they stay in the AC. A for Acinetobacter. So cephalosporin will not work on Acinetobacter and Campylobacter jejuni, and one more is Clostridium difficile. So in these infections, we are not going to use cephalosporins. So MRSA, atypical bacteria, Listeria monocytogenes, Enterococci, Acinetobacter, Campylobacter jejuni, and Clostridium difficile. So once you know where they are ineffective, so there is a possibility of questions. So once we know this mechanism, we know the spectrum of activity and where they don't work, it's important that we know the generations of cephalosporin. So in the first generation, we can classify them depending on the route of administration, the oral drug and the IV drug. So the IV drug and the oral drug, let us discuss. The oral drug is called cephadroxil. So the name is cephadroxil. Cephadroxil is used for the respiratory infections like upper respiratory tract infection and lower respiratory tract infection. The IV drug is called cefazolin. Now this is very, very important. You have to mark. Cefazolin is the drug of choice for surgical prophylaxis. Now what do you mean by surgical prophylaxis? Before the surgery, we give this drug. Why? Because during surgery, if there is a chance of infection, it can prevent that. That's why it is called prophylaxis. Mark this MCQ. So that is cefazolin for you. One more drug which is a parenteral or IV drug is called cephalosporin. Cephalosporin is not used nowadays because it is known to produce nephrotoxicity. So it is highly nephrotoxic drug. So we are not using that cephalosporin. So in this generation, main drug you all should remember is cefazolin. If you know the drug, you will be jolly in the exam. Cefazolin, yes. Now moving on to the second generation here. Second generation cephalosporins. Second generation cephalosporins. Again, you can give them oral. You can give them oral or you can give them parenteral. So what are the drugs which are given oral? The name is called cefuroxime oxetil. The name is called cefuroxime acetyl and cefaclor. It is called as cefaclor. Cefaclor. Now, if you know cefuroxime acetyl, so if you want a parental drug, remove the oxetyl. If you remove the oxetyl, you get a parental drug. The name is called cefuroxime. So that is given parental. Okay. Then we have certain drugs called cephamycins. Cephamycins. So what are the drugs in cephamycin, sir? In cephamycin, we have a drug by the name cefoxitin. Cefoxitin. And we have cefotitan. Cefotitan. And one more is cefmetazole. It is called cefmetazole. Now, what is the importance of knowing cephamycins? What is the importance of knowing cephamycin? Cefoxitin, cefotitan, cefmetazole. These are effective on an anaerobe. What anaerobe are they effective? The anaerobe they are effective is bacteroid fragilis. So this is a repeatedly asked question in the exam. Which cephalosporins are effective on this? And that is cefoxitin is repeatedly asked. Yes. So you can remember the drug cefoxitin. Then we have another drug. It is called cefomandole. It is called cefomandole. It is called cefomandole. So you can remember like this. If a man is furious, he will go to the bar. He will become tight. That is teton, and he will start seeing the fox. He is not really seeing the fox. Because of the alcohol, you see the fox, and the alcohol gets metabolized, metazole. So if a man becomes furious, furoxamine, he will go to the bar and become tight. Now that time you see the fox and the alcohol gets metabolized, metazole. So these are the things. And after the alcohol is metabolized, he will be cleared with the mind, klar, cefaclar, he is clear. So these are the second generation cephalosporins. Okay. Moving on to the third generation ones. Third generation. This is the one which you have to remember for your exam. Very, very important. Third generation. Again, we have the oral drug and then the parenteral drugs. What are the oral drugs? Remember, third generation drugs usually they end with IME. So let me write the drug name. Cefixime. So it ends with IME. Then one more drug is cefpodoxime. So again it ends with IME. It is called cefpodoxime proxetyl. Right. Then parental drugs. The parental drugs are ceftriaxone. Ceftriaxone. So they end with 1. Then we have cefoperazone. So again they are ending with 1. Okay, they end with like this. Or we have cefotaxime. So again they are ending with IME. Then we have ceftazidime. Again it is ending with IME. So these are the parental one. Now there are 2 exceptions which doesn't end like this. We have a very old drug not seen in your books, and that is called moxalactam. So moxalactam usually don't find in the book, but sometimes the examiner give that. It is also third generation. And one more oral drug is called cefdinir. It is cefdinir. So otherwise you can identify in the exam they end with either IME or they end with ONE 1. One more drug parental is called ceftriaxone. Again this ends with IME. Very good. So the only difference you have to find out is cefdinir and moxalactam. Now this is the generation which is very, very important for your exam. Please remember these drugs. Particularly you have to remember the drug by the name ceftriaxone. Very, very famous drug. You should never forget this. The name is called ceftriaxone. The name is ceftriaxone, and ceftriaxone is long acting. Now, first of all, we need to understand certain points here. It is a drug of choice for gram-negative infections. So, gram-negative infection, if they are very serious, then it is a drug of choice. Usually, it will cover gram-negative, so it is a drug of choice for that. Second important, it's a drug of choice for STD. What are the STDs? One is gonorrhea. Now the question is, when we use it for gonorrhea, will you use single drug or combination? Think and tell me. It's a single drug. So this is the question asked. And one more is chancroid. It is a drug of choice. It is a drug of choice for typhoid. It's a drug of choice for typhoid. And also, it is the empirical drug of choice for meningitis. Now, what do you mean by empirical drug of choice? What do you mean by empirical? Empirical means patient comes in meningitis. We don't know what is the bacteria causing that, but we cannot wait for the culture sensitivity to come. So until that, we start the therapy. That is called empirical. Without knowing the causative organism, if you are treating, that is called empirical. So it is the empirical drug of choice for meningitis. Another important, it's a drug of choice for a group of organisms called HACEC. They are called HACEC organisms. So what are these organisms? They are normally colonize the oropharynx. They will be there in oropharynx, and they are known to produce infective endocarditis. For these conditions, it is a drug of choice. Let me repeat again. It is a drug of choice for serious gram-negative infection, STDs like gonorrhea, chancroid, typhoid, empirical drug of choice for meningitis, and it's a drug of choice for HACEC organism. So very, very important. Now, when I am talking about ceftriaxone, I want to talk about certain infections here, which are commonly asked in the exam. Typhoid. Now, when you think of typhoid, we need to understand three important aspects here. What we need to understand about typhoid is, what is the drug of choice for typhoid? The drug of choice is ceftriaxone. So ceftriaxone is given IV, that is the drug of choice. If ceftriaxone is not given, alternative drug, what we can give is cefotaxime. Why ceftriaxone is the drug of choice? Number one, it is very long acting. Number two, it is undergoing bile elimination, so it can kill the bacteria in the bile also. Second, you can also give oral drugs for typhoid. The oral drugs what we have is cefixime. Then we have ciprofloxacin. And we have another drug called azithromycin. So these are options for us, but the major drug is ceftriaxone. This is the drug of choice. Very good. But there are carriers of typhoid. Carriers. I think you have heard of typhoid Mary. And if they are carrying, they are going to spread the infection to everyone. For the typhoid carrier, the drug of choice is ciprofloxacin. Ciprofloxacin is the drug of choice. So two potential questions from this. One is from ceftriaxone, one is from ciprofloxacin. The drug of choice for, so drug of choice for typhoid is ceftriaxone, carrier is ciprofloxacin. Very good. Now another important thing you need to understand is meningitis. Meningococcal meningitis. So meningococcal meningitis, you need to consider these options. If the patient, if you see that it is effective with penicillin, so if the meningococcal is penicillin susceptible, then you have to give penicillin only. If not, the drug of choice is ceftriaxone. The drug of choice is ceftriaxone. Now there is a chance when there is meningococcal meningitis, we need to give prophylaxis. We need to give prophylaxis. So what are drugs for prophylaxis? They are ceftriaxone, then ciprofloxacin, and we have another option, that is rifampicin. So which one is best? I have written in the order only. Ceftriaxone is best, then ciprofloxacin. In our country, rifampicin should be used for TB and leprosy, not for the smaller infections. So that's the reason prophylaxis. So two infection I have discussed here: the typhoid, very common infection, meningococcal meningitis. Now I told you, I'll repeat this point again. If the patient comes with meningitis, the empirical drug of choice for meningitis is ceftriaxone, because it covers most of the bacteria causing meningitis like H. influenza, then staph, strepto, and all those things. So the drug of choice is ceftriaxone. But one meningitis, ceftriaxone will not work. What is that? One meningitis, ceftriaxone will not work. That is, if the meningitis is because of listeria. So if it is listeria meningitis, then you have to change the treatment, and the treatment will be ampicillin. The treatment would be ampicillin. Otherwise, most of the bacteria causing meningitis can be treated with ceftriaxone. Very, very important. So this is what the importance of ceftriaxone. Never miss this drug for your exam. Very, very important. Now, when I think of ceftriaxone, we need to understand the pharmacokinetics of this drug. Ceftriaxone. The name itself is telling you triumph. So everywhere we are using it. Now, number one, pharmacokinetically, it undergoes bile elimination. So what is the advantage? The advantage is it is safe in renal failure. And when it is safe in renal failure, the question asked in exam is, do you require dose reduction in renal failure? No. No need of dose reduction in renal failure. Not only it undergoes bile elimination, it also undergoes renal elimination. But the point is, it is safe in renal failure. Should we reduce the dose in renal failure? No. You write that point also. No dose decreased in renal failure. The name is ceftriaxone. Now, another pharmacokinetic importance is the drug can displace bilirubin from the plasma protein. So the bilirubin is displaced from plasma protein. Particularly, this problem can occur in neonates. Neonates, that is less than 1 month or less than 28 days, they are called neonates. In them, it can displace bilirubin and cause kernicterus. So there is a chance of kernicterus. So don't use ceftriaxone less than what? 28 days. So what should we give for neonate? Preferred one is cefotaxime. Now remember, cefotaxime and ceftriaxone are brothers. They have same features. But only problem is ceftriaxone is longer acting. That's the advantage. Problem is cefotaxime is shorter acting. That's it. Otherwise, cefotaxime is also a very good drug. You may ask a question, sir, will cefotaxime displace bilirubin? No. Only ceftriaxone does that. That too in neonates. Okay. So these are the special point. Now, another special point is, if it is undergoing bile elimination, it can form a biliary sludge. It can form biliary sludge in the gallbladder, and it looks like a stone. It is called as pseudolithiasis. So ceftriaxone can produce pseudolithiasis or biliary sludge. It's a question repeatedly asked in the exam. So the beautiful drug ceftriaxone, you should know it in and out. Now once we know that, another beautiful drug we need to remember is cephalosporins. Cephalosporins is one of the beautiful drug which has activity on Pseudomonas. So it has anti-Pseudomonas property. The question is whether ceftriaxone has Pseudomonas activity. No. Ceftriaxone doesn't have Pseudomonas property. So it's very important. The examiner can frame a question. Does ceftriaxone have activity on Pseudomonas? You write down, you mark it. No effect on Pseudomonas. No effect on Pseudomonas. No effect. Now come to the drug. The drug what we are discussing is cephalosporin, which has anti-Pseudomonas property. What are the other drugs which have anti-Pseudomonas property is ceftazidime. Ceftazidime. And remember, these drugs have Z in their name: cephalosporin, ceftazidime. And one more older drug which you have forgotten, and that is called moxalactam. These are the drugs which have anti-pseudomonal property. Anti-pseudomonal property. So very, very important point. Only these drugs cover that. Now one more drug which has anti-pseudomonal property, which is a derivative of ceftazidime. It's a derivative of ceftazidime. It is called ceftolozane. It is called ceftolozane. It's a derivative of ceftazidime. So derivative. Why the questions about Pseudomonas? Because remember, Pseudomonas is very common in hospital. That's why the question comes. The third generations are cephalosporin, moxalactam, ceftazidime, and recently you can see this also. Ceftolozane also has Z. It has action on Pseudomonas. Now let us discuss the specialty of cephalosporin. Cephalosporin also undergoes bile elimination. So usually the drugs ending with 1, they undergo bile elimination. A clue for you, and this is safe in renal failure. Again, a repeatedly asked question for you. Safe in renal failure. One more important thing you all should remember: since it undergoes bile elimination, what happens? Cephalosporin comes in only bile, but ceftriaxone comes in bile and kidney. Since it comes in the bile, it can cause what adverse effect? It can cause severe diarrhea. It's a super infection. Severe diarrhea by killing the normal flora. Severe diarrhea. Second problem is it can produce a reaction called disulfiram like reaction. It can produce disulfiram like reaction. Now why the problem of disulfiram like reaction is seen? Now these drugs have a moiety called N-methyl thiotetrosol. So they have N-methyl thiotetrosol. This question is also asked, why it will cause disulfiram reaction? Cephalosporin, because it has the N-methyl thiotetrosol in its structure. It is also responsible for decreasing the prothrombin. So prothrombin is required for the clotting, and if the prothrombin is decreased, there is a risk of bleeding. Recently, again the question came, patient came with hemarthrosis, bleeding in the joint space. What antimicrobial is responsible? Again the question had repeated, it is cephalosporin. Cephalosporin is responsible for that. And the group is also asked N-methyl thiotetrosol. You may ask a question, sir, what are the other drugs which have this structure and it is responsible for disulfiram reaction and bleeding? Yeah, they are nothing but cefomandole, cefotitan, and one older drug, moxalactam. They all have the N-methyl thiotetrosol in their structure, and they both can cause disulfiram like reaction and bleeding risk. So patient who has already consumed alcohol, and for him, if these drugs are given, or patient is already on the drugs and he takes alcohol, he is going to have disulfiram like reaction. How to remember this? If a man drinks alcohol, he will become tight, tetan, and he will go to the opera. He will go to the opera zone and sings a song. If a mandol, becomes tight, tetan, he will go to the opera zone. And one more drug you have to remember is moxalactam, very old drug. Usually questions will not come from that. So they can cause disulfiram reaction and they can decrease the prothrombin and they can cause bleeding. So if you're using it with warfarin, there is a risk of bleeding. So they decrease prothrombin, and what time they increase? They can increase the prothrombin time. Yeah. So that is about cephalosporin, very beautiful drug for MCQs and very beautiful drug covering Pseudomonas. Okay. Now moving on to the next important drug, the name is called ceftazidime. So it has Z in the name. So will it cover Pseudomonas? Yes. It is a drug of choice for melidiosis, and also it's a drug of choice for Pseudomonas. Now, please remember, for managing Pseudomonas, we are not using single drug. The reason why we don't use single drug is, if I use single drug, there is a chance of resistance. If I have double drugs, resistance will not be there. So that's why we combine ceftazidime plus aminoglycosides. So the aminoglycoside of choice is gentamicin. So that is preferred. So that is about the third generation cephalosporins in detail, and I discussed some of the infection where they are very, very important. Moving on to the fourth generation cephalosporin. Fourth generation, and all are parental drugs. They are all parental drugs. The examples are cefepime, and one more is called cefpirone. Now they are used for what? They are used for resistant gram-negative infections. Question number 2. Are they going to work on Pseudomonas? Yes. They can act on Pseudomonas. Very, very important point. So that is about fourth generation. They are all given parenteral, and they are reserved drug for resistant gram-negative infections. That's it. The last generation is the fifth generation cephalosporin. Fifth. Now the fifth generation are also parenteral drugs. They are all given as injections IV. Now what is the name of them? The name of them is cephalosporin. The name is called cephalosporin, and one more is called ceftaroline. Now cephalosporin has same activity like ceftazidime. So it has same activity like ceftazidime for gram-negative. Now before I come to that, let me tell you one interesting fact about these drugs. Now these drugs, when we use them, when we give them IV, these drugs are prodrugs. So these drugs are prodrugs, and after metabolism, these drugs become active. So these drugs are prodrugs. Cephalosporin and ceftaroline are prodrugs. When we give IV, then they become metabolized and then become active, and they are having anti-MRSA property. They have anti-MRSA property. The only beta-lactam which has MRSA property is these drugs, and they are given in resistant gram-negative infections. Resistant gram-negative infection. And can we use it in Pseudomonas is a question. Now remember, cephalosporin, ceftaroline, you can compare these drugs to one more drug. Cephalosporin has same activity like ceftazidime. So if you ask the gram-negative action of cephalosporin, the gram-negative activity is similar to ceftazidime. If you take the example of ceftaroline, the gram-negative activity is similar to ceftriaxone. So the gram-negativity activity is similar to ceftriaxone. Now you tell me, pause the video, which of these two can work on Pseudomonas? Yes, if you are thinking cephalosporin, you are correct. So cephalosporin has activity on Pseudomonas. Ceftaroline, since it has similar property like ceftriaxone, gram-negative activity, no action on Pseudomonas. So these are the potential questions for you in the future exams. Very, very important. So this is about the 5 generations of cephalosporins. Please remember them. Particularly the concentration should be on ceftriaxone, then cephalosporin and ceftazidime. Then you have to by heart cefepime, cefpirone, ceftobiprole, ceftaroline. Very, very important. There is no shortcut for fourth and fifth. You have to buy them. Now, what is the adverse effect of these drugs? Since they are also obtained from fungus, they are also producing allergy, that is hypersensitivity can be seen. They also have cross allergy, and they can produce a super infection, that is pseudo membranous colitis. So they can cause pseudomembranous colitis leading to diarrhea. So which generations are more common? It is most commonly seen with the third generation cephalosporin. So this is seen with third generation. Why? Because we use them extensively. That's why it is seen. So other adverse effect I have told you, cephalosporin is highly nephrotoxic, disulfiram, bleeding, all those things we have discussed. Then moving on to the new drug, a new cephalosporin. The new drug, the name is called Cephalosporin. It is called cefiderocol. So the name seems different, cefiderocol. The meaning of this cefiderocol is it enters the bacteria. So in the bacteria there is a space called periplasmic space. So you have the cytoplasmic membrane, above that there is periplasmic space. So it enters periplasmic space. So the entry is through a transporter called siderophore. So it is called siderophore. Now what is a siderophore? It's a transporter for iron. So through that system the drug enters the bacteria. Usually the bacteria, they have something called porine channels through which the drug enters. But this drug can enter through another transport channel, that is called siderophore. So it enters the periplasmic space with the help of siderophore. That's why the name is cefiderocol. So what is the advantage of this? It has increased stability for beta lactamase. Increased stability for beta lactamase. So you know that beta lactamase are the one which will cut the beta lactam, and it has very good stability. So most of the beta lactamase cannot cut this. So that means we can use it in resistant infections. So many times they ask this question, sir, which generation is it? Now it doesn't have any generation. It has the chemical structure similar to, the chemical structure of this drug is similar to, in third generation it is similar to what? In fourth generation it is similar to what? So it has structure similar to ceftazidime, and in fourth generation it has structure similar to cefepime. So it is not being allotted any generation now, but the structure is like this. Now where to use it? It is used in complicated UTI, one of the reserve drug. It's like a nuclear weapon. We don't use it every day. It is a reserve drug. And also it is used in hospital acquired bacterial pneumonia and ventilator associated bacterial pneumonia, VBAP and HABPAP. So hospital acquired bacterial pneumonia and ventilator associated bacterial pneumonia, we use the drug called cefiderocol. It's like a reserve drug. So nowadays the problem is resistance. So if you don't have any drug, then only we use this drug, that is cefiderocol. So once we are done with cephalosporins, let us discuss one more beta lactam. The name is called carbapenems. The name is carbapenems. Now what is the spectrum of activity? Spectrum is they can cover gram positive, gram negative, and they can also cover anaerobes. So they are like a reserve drugs. Mechanism of action is similar. They also inhibit transpeptidase and they inhibit cell wall synthesis, similar to penicillin cephalosporins. So the first drug here is called imipenem. Now what is the specialty of imipenem? Let me draw the nephron for it. This is the nephron. Yes. So in the nephron, we have the cells here and they express an enzyme called dehydropeptidase. Dehydropeptidase. Now what happens when we give imipenem. Imipenem is filtered. When it comes to the nephron, it is metabolized by the enzyme dehydropeptidase. So this will metabolize imipenem. So what happens if imipenem is metabolized? It cannot be reabsorbed back. It will not be reabsorbed back. Now tell me, if it is not reabsorbed back, whether the drug is short acting or longer acting. Obviously short acting, because imipenem is not going back, it is going out, so the drug is short acting. So this enzyme will do two things. It will make the imipenem short acting, and the metabolite of imipenem will be a toxic metabolite. So it will produce a toxic metabolite, and that is going to cause nephrotoxicity. That is going to cause nephrotoxicity. So what should we do now? What should we do now? Think and tell me. Inhibit the enzyme dehydropeptidase, and that is inhibited by a drug called cilastatin. So cilastatin is the inhibitor of dehydropeptidase. So when I use that with imipenem, what is the advantage? The drug becomes longer acting and there is a reduced chance of nephrotoxicity. So let us write what is the advantage of combining imipenem plus cilastatin. Let me explain again. If I give imipenem alone, the drug is metabolized and it produces a toxic metabolite in the kidney, leading to nephrotoxicity, and the drug is shorter acting. Now if I inhibit the enzyme, what is the advantage? Advantage number one, the drug becomes longer acting. So that means there is increase in duration of action. Second, less nephrotoxicity. So the toxicity is reduced. So this is the advantage of combining imipenem plus cilastatin. Again, two questions were asked. This was asked. Now carbapenems are known to produce seizures. Among carbapenems, imipenem has shown to produce maximum seizures. So this is again a potential question. Carbapenem causing maximum seizure is imipenem. Now what about the other penems we have? The other penems what we have is doripenem. Then we have meropenem. Then we have ertapenem. Now remember, these can cover Pseudomonas, but ertapenem has less effect on Pseudomonas. It is less effective on Pseudomonas. Very, very important point. And we have an oral preparation of carbapenem that is called pharopenem. It is called as pharopenem. You may ask a question, sir, should we add cilastatin for doripenem, meropenem, ertapenem, pharopenem? No need. They are not metabolized by that enzyme dehydropeptidase. So there is no need for that. So once we know the mechanism of action, spectrum of activity, specialty of the drug, let us understand carbapenems as drug of choice. Carbapenems are drug of choice for what? They are the drug of choice for serratia, and then Enterobacter, then ESBL producing bacteria. What is ESBL producing? Extended spectrum beta-lactam is producing bacteria. We can use it. And also it is used in managing Acinetobacter. So you can remember by the mnemonic C. S-E-A-C. Serratia, Enterobacter, ESBL producing bacteria, and all this Acinetobacter, it is the drug of choice. And remember, this is one of the reserved drug. We don't use it for, suppose a patient comes with sore throat and all, we don't use it. It's a reserved drug for serious infections. That is carbapenems for you. Yes, so once we are done with carbapenem, the last beta-lactam which we are going to discuss, the name is called monobactam. So the name itself is telling you mono means it is a solo. It has only the one ring, that is beta-lactam ring. It has no thiazolidine ring. Now What is the name of the drug? Aztreonam. So it looks like Theranam, Salman Khan movie. So monobactam, mono, alone. So Theranam also it will be alone. Monobactam, the name is Aztreonam. Now the specialty of Aztreonam is it is going to work on gram negative only. Second, it has no cross allergy. It has no cross allergy with other beta lactams except a drug by the name ceftazidime. You may ask a question, sir, why with ceftazidime? Because ceftazidime has similar structure. Aztreonam, ceftazidime structures are similar. That's why if they have allergy to the ceftazidime, there is a chance of allergy to Aztreonam. Otherwise, other beta lactams that doesn't have cross allergy. That is Aztreonam, remember the name, Theranam, monobactam. So that is about the beta lactams. So we discussed the cephalosporins, then carbapenems and monobactams in this video. Particularly, you have to consider on ceftriaxone, very important drug of choice for typhoid, gonorrhea, chancroid, serious gram-negative infection, Hackett organisms. It is eliminated in bile, so it can cause biliary sludge, pseudolithiasis. Less than 1 month, it can cause bilirubin displacement, so better to shift to cefotaxime. Cephalosporins, ceftazidime, moxilactam, and ceftolozane, they have activity on Pseudomonas. Ceftriaxone doesn't have activity on Pseudomonas. Ceftazidime is the drug of choice for melioidosis. It's a drug of choice for Pseudomonas along with aminoglycoside. Now remember the drugs ending with ONE1, they are eliminated in bile, safe and renal failure. Cefepime, cefpiram are 4th generation parenteral drugs. 5th generation are ceftobiprole, which has similar gram-negative action like ceftazidime. So it has action on Pseudomonas. Then ceftaroline has similar action like ceftriaxone. It doesn't have activity on Pseudomonas. Now 5th generation specialty is they have anti-MRS action. They are used in serious resistant gram-negative infection, and they are also used in pneumonia cases. Right. Now, once you know that, they will ask you disulfiram-like reaction. The reason for that is they have N-methyl thiotetrosol. What are the drug names? Cephalosporin, cefamandole, cefotitan, and moxilactam. These drugs are also responsible for decreasing the prothrombin levels. So that will lead to bleeding. Very commonly asked question in exam. Then carbapenem, we use imipenem with cilastatin to increase the duration of action and to decrease the toxicity. And imipenem has maximum seizures among carbapenems. Carbapenems are the drug of choice for Serratia, then Enterobacter, ESBL producing bacteria as well as Acinetobacter. Monobactam, we have only one drug, Aztreonam, no cross allergy except ceftazidime, and it is effective for gram-negative only. So that is about cephalosporins, monobactams, and carbapenems. Thank you all.